inflammatory disease resulting from systemic immune response involving mainly the joints, heart, and less frequently skin, years. And the sequel, rheumatic is a sequel of group A beta hemolytic streptococcus, whereas the arthritis is autoimmune. And your fever mainly affects the larger joints and it is fleeting type of pain, usually diagnosed by the diagnostic criteria. Whereas the rheumatic arthritis, it mainly affects the peripheral smaller joints and it is bilaterally symmetrical, which is diagnosed also by criteria, but different criteria. Rheumatic fever usually doesn't have a morning stiffness. Rheumatoid antibodies are negative. Subcutaneous nodules are present. Erythema marginatum is present, and joint deformity is absent. And cardiac involvement is common. Whereas constrictive pericarditis is never seen in rheumatic fever. Whereas in rheumatoid arthritis, the constrictive pericarditis may cause there is no cardiac involvement and there is no erythema marginatum and there is no subcutaneous nodule. There is a rheumatoid nodule. And rheumatic fever also has chorea. And the treatment of rheumatic fever is prophylactic penicillin, whereas rheumatoid arthritis is DMRTs, which are steroids. Whereas rheumatic fever sequel may progress to rheumatic heart disease, which is valvular lesions. It leaks the joints and kills the heart. Whereas rheumatoid arthritis does not involve the heart. Carditis is the one more clinical feature of rheumatic fever. It is one of the most serious manifestations of rheumatic fever, and it may lead to rheumatic heart disease, heart failure, atrial fibrillation, stroke, infective endocarditis, and even death. It may be asymptomatic, but detected mostly during evaluation of arthritis or chorea. Its incidence varies, with 90% in children with less than 3 years, 50% in 3 to 6 years, 32% in teens, 15% in adults, and up to 91% when clinical examination plus echo are used. The most common valvular lesion is mitral regurgitation, causing an apical pansystolic murmur, and aortic regurgitation is less common. Stenotic lesions are uncommon in the early stages of disease, but a transient apical mid-diastolic murmur, which is Carey-Coombs murmur, may occur in association with the murmur of the mitral regurgitation. In patients with a history of previous rheumatic heart disease, a change in the character of the murmur or the appearance of a new murmur will indicate the presence of acute rheumatic carditis. And echocardiography is one of the more sensitive and specific than cardiac auscultation for the detection of acute rheumatic carditis, such that it recommended that all patients with suspected or definitive rheumatic fever should undergo echocardiography. The World Health Federation for minimal echocardiographic criteria for diagnosis of pathologic valvular regurgitation caused by rheumatic carditis shows that for any pathological mitral regurgitation or pathological aortic regurgitation, the echo should be done in at least two views. And in at least one view, the jet length should be more than or equal to 2 centimeters with a peak velocity of more than or equal to 3 meters per second and a pansystolic jet in at least one envelope. Whereas aortic regurgitation length should be more than 1 centimeter. The clinical diagnosis of carditis is based on the detection of an organic murmur that was not previously present, which indicates the endocarditis, presence of a pericardial friction rub or signs of pericardial effusion to indicate a pericarditis, or cardiomegaly or cardiac congestive heart failure to indicate myocarditis. The myocarditis without valvulitis is unlikely to be rheumatic. Usually, they present with an apical systole or a basal diastolic murmur, cardiomegaly, and congestive heart failure, which may be life-threatening. And ECG sometimes shows varying degrees of heart block, which is first degree heart block, usually asymptomatic with a prolonged PR interval. Second degree or third degree heart block may requiring pacing if congestive heart failure develops. The congestive heart failure usually occurs in 5 to 10% of initial attacks and is more common in recurrent episodes due to myocarditis or severe valvular disease. Other feature is pericarditis. They usually present with anterior chest pain and a pericardial friction rub. Usually clinically detectable in about 10% of the patients, and pericardial effusion may be large, but tamponade is rare and constrictive pericarditis does not occur. Syndonans chorea may be the sole manifestation of rheumatic fever, more common in females, especially post-puberty. Usually occurs 6 to 8 weeks after the gaspharyngitis, which has a longer latency period than arthritis or carditis. It is characterized by involuntary jerky movements, hypotonia, and motor impersistence. Example, Jack in the Box tongue milking sign. It often involves emotional liability, irritability, mood swings, and learning difficulties. Usually, it lasts between 8 to 15 weeks, and it also can range from 1 week to 2 years. ESR, CRP, and ASO titers may be normal due to its delayed onset. It may coexist with carditis, but not with arthritis. Pandas, which is gas-triggered tics or OCD without carditis, is controversial in high-risk populations. Then rheumatic fever should be favored and secondary prophylaxis should be given. Subcutaneous nodules, it is a rare manifestation of rheumatic fever occurring only in 1.5% of the cases, and it's more common in children and with prolonged active carditis. It's found over bony prominences like occiput, elbows, olecranon, knee, ankles, and Achilles tendon. It is firm, painless, movable, 0.5 to 2 centimeters in size, and usually appear as in crops. It is typically transient, which lasts for less than 1 month, smaller and lesser persistent than rheumatoid nodules. Erythema marginatum, uncommon manifestation of rheumatic fever, seen mainly on the trunk and upper arms, but not the face. It is evanescent, pink, non-itchy rash with centrifugal spread and serpiginous borders. It often appears with carditis either early or later in the disease. It may become more prominent after a hot shower, helpful but not specific for the diagnosis. Other manifestations, usually fever, which is 38.4 to 40 degrees centigrade, is common, but a cutoff of the more than 37.5 degrees captures 94% of the cases in endemic areas. It usually lasts for less than 1 week and rarely beyond 4 weeks. The arthralgia is defined as a subjective pain, whereas arthritis means subjective symptoms as well as objective signs of joint inflammation. It is one of the minor criteria. Previous rheumatic fever or rheumatic heart disease, this minor criteria is applicable only for a second attack of rheumatic fever. Abdominal pain may mimic appendicitis. Epistaxis was one common but is now very rare. Other features are tachycardia, disproportionate to fever, rapid sleeping pulse, malaise, and anemia. Rheumatoid pneumonia is rare and hard to distinguish from pulmonary edema or alveolitis. The diagnosis is mainly used based on the clinical criteria, which was first formulated by T. Duckett Jones, and the most recent revised Jones criteria, according to American Heart Association 2015, is being followed. In case of initial acute rheumatic fever, it requires two major criteria or one major plus two minor criteria and with an evidence of recent gas infection. Whereas recurrent acute rheumatic fever, it requires two major or one major plus two minor or three minor criteria with prior gas infection. Evidence of gas infection includes it should have a positive throat culture, only 11% have a diagnosis, and raising anti-streptococcal antibodies or anti-DNase B antibodies, and a recent scarlet fever or high clinical suspicion of gas pharyngitis. This is Jones criteria according to the American Heart Association 2015. It includes major criteria and minor criteria based on the high risk populations and low risk populations. In low risk populations, the major criteria are carditis, which is clinical or subclinical, arthritis, only polyarthritis, chorea, erythema marginatum, and subcutaneous nodules. Whereas in a low risk population, it includes polyarthralgia, uh, fever of more than or equal to 38.5 degrees, ESR of more than 60 mm in the first hour, or CRP more than equal to 3 milligram per deciliter. Prolonged PR interval after accounting for age variability, unless carditis is a major criteria. Whereas in a moderate to high risk population, the difference is that carditis is both clinical and subclinical, but the arthritis, it includes polyarthritis, monoarthritis along with polyarthralgia. Chorea, erythema marginatum, subcutaneous nodules, and moderate and high risk population, the difference between low risk and high risk is if low risk has polyarthralgia, whereas high risk has monoarthralgia. And the ESR is more than 30 mm in the first hour, or CRP of more than 3 milligram per deciliter is considered as higher, moderate and high risk population. In carditis is usually defined by echocardiographic valvulitis, and the polyarthralgia, it should be considered only as a major manifestation in moderate and high risk populations after exclusion of other causes of polyarthralgia. And the CRP value must be greater than the normal laboratory upper limit, which is more than 3 milligram per deciliter. In addition, because the ESR might involve during the course of acute rheumatic fever, the peak ESR value should be used. The joint manifestations are only considered in either the major criteria or the minor criteria, but not together in both the criteria in the same patient. Subclinical carditis, usually detected by echocardiography, is now accepted as major criteria for all populations. And risk-based stratification introduced, which are the low-risk populations are acute rheumatic fever with less than 2 per 1 lakh population, or rheumatic heart disease with less than 1,000 per 1,000 per year population per year is considered as low risk group, whereas the high risk or moderate risk group includes more inclusive criteria. In high-risk populations, monoarthritis and polyarthralgia are major criteria. Fever more than or equal to 38 degrees centigrade and monoarthralgias are minor criteria. And possible rheumatic fever acknowledged, diagnosed based on clinical judgment when full criteria cannot be met due to limited resources in a high-risk settings. In such cases of possible rheumatic fever, a 12 month of prophylaxis followed by re-evaluation is generally advised. Investigations wise, acute phase reactants, usually patients present with leukocytosis between 10,000 to 15,000 cubic millimeter, and an elevated ESR, which persists for 4 to 10 weeks in 80% of cases and may stay high beyond 12 weeks also. CRP is usually elevated in all cases, drops rapidly with steroids. Absence usually rules out acute rheumatic fever, but presence is not non-specific. ECG findings usually present with prolonged PR interval, which is a minor criteria and not specific for carditis. Higher degree AV blocks, which is Wenckebach phenomena, may occur, but complete block is usually rare. Third investigation is evidence of recent streptococcal infection, which is by anti-streptococcal O titers and anti-DNSB antibodies. A raising titer is most reliable. High single values alone or non-specific. Usually repeat the test after 10 to 14 days if the first test is not confirmative. Positive throat culture is usually rare at presentation, does not confirm rheumatic fever. Signs of scarlet fever, example skin desquamation, rarely or especially in India. Chest X-ray usually shows features of cardiomegaly or congestive cardiac failure. And whereas echocardiography, it is not included in revised Jones criteria, but highly sensitive for detecting rheumatic carditis. Usually they present with findings of annular dilatation, caudal elongation, mitral collapse, and valve leaflet thickening. Mitral or aortic regurgitation without chaotic motion helps rule out infective endocarditis. And it may detect subclinical carditis, echo evidence without auscultative findings. The subclinical carditis patients often require long-term penicillin prophylaxis. Tests for alternative diagnosis depending on the clinical features. Repeat blood cultures with temperature spikes if infective endocarditis is suspected. Joint aspirate for possible septic arthritis, microscopy and culture. Copper, ceruloplasmin, anti-nuclear antibody and drug screen for coriform movements. Serology and autoimmune markers for arboviral, autoimmune or reactive arthritis. Peripheral bed smear may be done for sickle cell disease. Treatment, the main treatment goals are one, to suppress the inflammation, to protect heart or joints, to eradicate the gas from the pharynx, to relieve symptoms, and to initiate secondary prophylaxis. The management approach, initially, the primary treatment is to suppress the inflammation, bed rest until fever subsides and acute phase reactants normalize. And antibiotics are suggested, which is single dose of intramuscular benzathine penicillin or erythromycin if allergic to penicillin, regardless of the throat swab culture. And the anti-inflammatory therapy with aspirin 100 mg per kg per day in divided doses, prednisolone 1 to 2 mg per kg per day for severe carditis, with a duration of 1 to 3 months based on the severity. Steroids versus aspirin, there is no clear advantage. Steroids are not proven to reduce long-term valvular heart disease. Fever may progress to valvular incompetence and heart failure. Valve surgery may halt disease progression and improve the outcomes. Prevention of rheumatic fever, primordial prevention, it addresses the social determinants that is poverty, overcrowding, and poor access to care, has historically reduced acute rheumatic fever incidence even before antibiotics. Primary prevention treats gas pharyngitis, intramuscular benzathine penicillin in 1.2 million units, 50% if less than 30 kgs of weight is 50% of the doses given, which is 0.6 million units. Oral penicillin, which is 250 to 500 mg TID for 10 days. Erythromycin for penicillin allergy patients, usually orally for 10 days is given. And treating 50 to 60 pharyngitis cases prevents one acute rheumatic fever case. Secondary prevention is to prevent the recurrence. Intramuscular penicillin is more effective than oral penicillin. Injections every 2 weeks is considered superior to every 4 weeks, with almost 50% showing reduction in the risk of recurrence. WHO recommends every 3 to 4 weeks, but bi-weekly is the best for high-risk cases. Drug regimen of choice for secondary rheumatic prevention of rheumatic fever is penicillin, which is single intramuscular injection every 3 to 4 weeks, or preferably every 2 weeks. For adults and children for more than 30 kg in weight, 1.2 million international units is used. And for children less than 30 kg in weight, 60,000 international units is used. 6 lakh international units is used. Penicillin V is oral, which is 250 mg twice daily for till the lifelong. Or sulfonamide, which is oral for adults and children who are more than 30 kg in weight, 1 gram daily. For children less than 30 kg in weight, 500 mg daily. And erythromycin first attack, or at least until 21 years of age, whichever is longer. Rheumatic fever without carditis, 5 years or until 21 years, whichever is longer. In case of more severe valvular disease, lifelong prophylaxis is considered, and after valve surgery, lifelong prophylaxis is mostly considered. Thank you, sir.
Yeah, you only talked about acute rheumatic fever because the more important thing for us as cardiac surgeons is chronic valvular heart disease, rheumatic heart disease. Few questions I have. One is, in the last 45 years, I have not been able to find the reason why you get migratory polyarthritis in rheumatic fever, and why that arthritis completely settles down and moves to another joint. If any of you can find some sort of reference or some explanation for that, please educate me on that. Second, you said the most common manifestation is MR in acute rheumatic fever, whereas in chronic rheumatic fever, it is usually mitral stenosis. Okay. Do you know the reason? In acute MR, there is, as you mentioned, an acute rheumatic fever, as you mentioned, there is pancarditis, valvulitis, pericarditis, and myocarditis. So the MR, the closure of the valve, becomes defective, and you have MR presenting. But in chronic rheumatic fever, it is the valve is subjected to repeated stress, and that causes fibrosis, especially at the commissures, and then it progresses towards the central part of the lumen. The reason being, the mitral valve is the commonest valve that is affected in rheumatic fever, because it is a valve situated between two highly difference in pressure. The LA pressure is around 4 millimeters of mercury, whereas the LB pressure is almost 80 to 120 millimeters of mercury. So there is a gross difference in the pressure, and that valve is subjected to severe strain, and that is why that gets affected with fibrotic lesions and then further progression. So these are the two things that you have to know. And sometimes the examiner will ask you what is the characteristic or the pathognomonic feature of rheumatic fever, and that is, as you rightly said, is the Ashkoff nodules. But at the same time, when you're operating, you also have something called the McCallum patch on the LA, where the mitral regurgitation hits the LA wall. You have a patch-like thing there on the LA posterior wall, and that is known as the McCallum patch. All right.
Okay.
Now, during penicillin prophylaxis, we used to say that initially the injection should be given once in 3 weeks, deep intramuscular. Yes. Do you know the reason?
Because of the latency period is 1 to 3 weeks.
No, because the half-life of the injection, penicillin, it lasts 21 days. So that is why it used to be given once in 3 weeks, and deep intramuscular injection, and it is extremely painful. And that is why many patients used to drop out and default with the prophylactic regimen. And that is why they used to get secondary rheumatic fever and further carditis. So people do generally, even in tuberculosis, people don't like to take the drugs for a long time, and then after 2 to 3 months they feel bored and this thing, and then they stop their treatment. So the compliance of prophylaxis is very, very important in both tuberculosis and rheumatic fever, and more so with the rheumatic fever because it is a painful injection. All right. And then you go back to that slide on the prophylaxis. We said the rheumatic fever prophylaxis is usually given for at least the time when the patient reaches 40 years, right?
Yes, sir. Yes, sir.
Until the age of 40 years, or
Yes, sir.
10 years following the last attack, whichever is later.
Yes, sir.
All right. So if you get 10 years at 30 years, you will still continue it to 40 years. That used to be the standard teaching. But there are some units which continue, especially after surgery, to continue the prophylaxis lifelong. All right. So now I have a question for you. What do you do in a case of double valve replacement? Do you continue the prophylaxis lifelong, or do you stop somewhere in between, or what is the logic, or what is the criteria for this, and what do we do in NH?
Uh, in NH, I have seen up to 40 years of age, we give the
No,
prophylaxis
understand
administration.
my question. It's a specific question. You have done a double valve replacement. Both the aortic and the mitral valve are replaced. So there is no chance of further
Chance of embolization.
involvement. So in such a situation, what do you do? If it's a single valve, you have to continue as the criteria said, 40 years or 10 years till the last one, and many a time you continue doing for lifelong. So in double valve, when there is no chance of a reinfection of the valve, so you have replaced both the valves, so it doesn't matter. So in such a situation, I used to practice of giving prophylaxis at least 5 years post-op, even in a double valve. In single valve replacement, we used to do continue it lifelong, if possible, or at least 40 till the patient achieves 40 years. The logic being, after 40 years, the chances of reinfection with group A streptococcus is bleak or not unlikely to happen. And so that is why people used to stop giving prophylaxis after the age of 40. Okay, these are few things.
Okay.
And you have to talk to your consultants, present practicing consultants in NH, especially like Ravindra Shetty or Sanjay Dade, who do a lot more valves than the others. Find out what is their practice, and then see how it is done. You understand?
Yes, sir.
So these are the things that you should know among rheumatic: how to identify Ashcroft nodules, what are the Jones criteria, what was the original Jones criteria, and what is the modified Jones criteria. I remember long ago, maybe 10, 15 years ago, one of the candidates in the exam kept on talking about Duckett Jones and his history rather than the Jones criteria. I was waiting for 10 minutes. He talked about Duckett Jones, but never came up to the criteria of the for the diagnosis of rheumatic fever. So you must know how it started, what was the original Jones criteria, and what is practiced now and why. Okay, these are the things that you have to know in acute rheumatic fever. Acute rheumatic fever pathophysiology, acute rheumatic fever prophylaxis is important, and the diagnostic features. Okay. And then, as I told you in the beginning, please find why something should have polyarthritis and migratory polyarthritis, and the previous joint will become completely normal. This is something very unusual. And why that happen? I don't know. I've never found a reason for it. So any of you, if you know the reason or have found this thing or do some research on that, please let me know. Okay.
Okay.
Any other questions anybody has? Nobody? I see Swecha logged in. Swecha, you have anything to add? You have now become a consultant.
No, sir.